Today I was asked to talk about the management of patients with relapsed and refractory disease, specifically the really challenging subset of patients with what we call double refractory myeloma. That is refractory to our current agents, the proteasome inhibitors like bortezomib and IMiDs like lenalidomide. In the United States, there's currently two medications approved for use in this setting. One is the next generation proteasome inhibitor called carfilzomib. In the pivotal study with carfilzomib, there were 266 patients treated, and these patients all had prior bortezomib and lenalidomide and refractory. And in that setting, there was about a 24% response rate, and those patients who responded had a median duration of response of about 8 months. And the other very promising agent also recently approved in the past year or so in the United States is pomalidomide, which is the next generation IMiD from thalidomide and lenalidomide. And pomalidomide in combination with dexamethasone was shown to be superior to single agent pomalidomide in a randomized phase 2 study. Response rates around 30%, and again, median duration of response of around 8 months. There was a large international study that compared pomalidomide, low-dose dexamethasone to high doses of dexamethasone, and again, very similar response rates. About 30% of patients respond. Again, this is a refractory setting, and clearly superior from response rate, time to progression, progression-free survival, and overall survival compared to dexamethasone alone. And so those are the two new medications available for patients with what we call double refractory disease that are both approved in the United States. I believe pomalidomide is approved in the United Kingdom and around Europe, and carfilzomib is waiting for approval based on their large phase 3 study. It's not been reported yet. That phase 3 study looked at combination of carfilzomib plus lenalidomide dexamethasone, and in a randomized fashion compared that to lenalidomide and dexamethasone alone, and we're waiting for those results. And assuming, or if those results are positive, I would assume that we would start to see approvals outside the United States for carfilzomib. And then there's a whole host of investigational agents, and I think probably the most exciting class of investigational agents in myeloma is the monoclonal antibodies. In lymphoma, we've been using monoclonal antibodies for going on 20 years, but in myeloma, we have yet to see an effective monoclonal antibody. And the one that is the most developed is a medication called elotuzumab. Elotuzumab is a monoclonal antibody against a cell surface glycoprotein that we now know as SLAM-F7. And SLAM-F7 is only on plasma cells and somewhat on NK cells. And it appears that elotuzumab works through the induction of ADCC, and we know that lenalidomide upregulates ADCC as an immune mechanism. And so the study that we did, we combined elotuzumab with lenalidomide dexamethasone, and we saw excellent results, response rates in the 90% range, progression-free survival in the 30-plus month range, which are far superior to what we would have predicted with lenalidomide dexamethasone alone. So again, elotuzumab lendex has moved forward with the phase 3 study to try to truly establish this as an effective therapy, and we're waiting on those results. And then there's two drugs, both targeting anti-CD38, one drug called daratumumab and another one called that we know as SAR, and both of those drugs as single agents have activity against refractory myeloma. And so we're waiting on further development of those monoclonal antibodies. With the proteasome inhibitors, particularly bortezomib, the major toxicity that limited us from using these medications for a long time was the development of peripheral neuropathy. And fortunately, carfilzomib has very little peripheral neuropathy and essentially no painful peripheral neuropathy. And so that has really established carfilzomib as a medication that could potentially be used for a long period of time. There are uncommon or, quite frankly, rare side effects with carfilzomib, including cardiac problems, shortness of breath, and so forth, that are not in a lot of patients, but it's the type of thing that people, as they use this medication for the first time, need to be conscientious of as a possibility. And from a pomalidomide standpoint, pomalidomide, as an IMiD that's similar to lenalidomide, has toxicity very similar to lenalidomide in that the most common toxicity, at least is hematologic in nature: myelosuppression, thrombocytopenia, neutropenia, and anemia. And a large part can be managed and predicted, and dose reductions really manage those toxicities. The other side effect that we've noted, and it's hard to really tease out whether it's specifically related to pomalidomide or it's related to the combination of dexamethasone, or because these are refractory myeloma patients, are frequent infections and pneumonia. So again, that's something to be conscientious about with pomalidomide. The other thing I have to mention is, just like any time we use the IMiDs, thalidomide, lenalidomide, and pomalidomide, we always have to think about DVT prophylaxis. And anytime we use any of the IMiDs in any circumstance, we always at least think about DVT prophylaxis. And for the standard risk patients, use aspirin. And for patients who are high risk, immobile, have a history of DVT, will need more aggressive anticoagulation. In terms of what's to be positive about in myeloma, where we previously would have predicted that patients with double refractory myeloma would live less than 1 year, now we know with these new agents, these new combination of agents, patients are living much longer and living, quite frankly, better lives because of better control of their myeloma.